Okay, this is part 2, chapter 19, and we're going to go over the physiology of circulation. And we're going to start off by talking about flow, pressure, and resistance. So now, definition of terms. Okay, so we have blood flow. And this is going to be the volume of blood flowing through. And this could be a vessel, it could be an organ, or it could be the entire circulation in a given period of time. It's going to be measured in mils per minute, and it's equivalent to cardiac output for the entire vascular system. Overall, relatively constant when at rest, but at any given moment, it can vary at the individual organ level based on needs. So what this means is, at rest, again, constant. But let's say you decide to go work out, right? If you decide to go work out, well, then blood flow is going to go to the skeletal muscle, and then it's going to be kind of shunted away from like the stomach, for example. Then we have blood pressure. This is a force per unit area exerted on the wall of the blood vessel by the blood. And it's expressed in mmHg, which is millimeters of mercury. And the pressure gradient is what provides the driving force that helps keep the blood moving from areas of high to low pressure. And then we have resistance. We're going to call this peripheral resistance, and this is opposition to flow. And this is the measurement of the amount of friction that blood encounters with vessel walls, generally in peripheral circulation, systemic circulation. And there are three important sources of resistance. There's blood viscosity, total blood vessel length, and blood vessel diameter. And we're going to talk about each one of these separately. So we start off with blood viscosity. And this is the thickness or the stickiness of blood due to the formed elements in plasma proteins. So remember, the formed elements are things like our red blood cells, our white blood cells, our platelets, and then an example of a plasma protein would be like albumin, right? So this stuff is circulating around in the blood, and the more formed elements and plasma proteins we have, the greater the viscosity. The greater the viscosity, the less easily molecules are able to slide past each other. And an increase in viscosity equals an increase in resistance. Then we had total blood vessel length. The longer the vessel length, the greater the resistance encountered. And then finally, we have blood vessel diameter. Now, blood vessel diameter has the greatest influence on resistance. And this is because it can change. So vessels, certain vessels can vasoconstrict, vasodilate, but frequent changes are going to alter peripheral resistance. Now, and this is in contrast to viscosity and blood vessel length, which are going to be relatively constant. Fluid close to the walls is going to move more slowly than in the middle of the tube, and this is called laminar flow. And then resistance varies inversely with fourth power of vessel radius. How complicated does that sound? What this means is, if the vessel radius increases, excuse me, the resistance is going to decrease, right? So if the lumen of the vessel gets bigger, the resistance goes down. Now, if the lumen of the vessel gets smaller, then resistance goes up. Now, because it's to the fourth power, it's going to, in the case of if the radius increases, resistance decreases, it's going to decrease by a lot. So, for example, if the radius is doubled, the resistance drops to 1/16 as much. Small diameter arterioles are the major determinants of peripheral resistance, and their radius changes frequently. And this is in contrast to the larger arteries that do not change often. Abrupt changes in vessel diameter or obstacles such as fatty plaques from atherosclerosis can dramatically increase resistance. What can happen is laminar flow becomes disrupted and becomes turbulent flow, and turbulent flow is irregular flow that causes increased resistance. So if you were to say have a milkshake in front of you and you were to be given a choice of two straws, which straw would you choose? I am hoping you're saying the shorter, wider, or larger lumen diameter straw, because that would be the correct answer. And even though it's in the morning, I now want a milkshake. So then we have the resistance between flow, pressure, and resistance. Well, there's equations down here. I don't expect you to memorize these equations, but I do want you to know the concept. And so because of that, it may actually be a good idea for you to remember the equation, because it may help you remember the concept. So here we have blood flow is F, okay? And it's directly proportional to the blood pressure gradient, which is going to be delta P. And that little triangle is delta. So if delta P increases, blood flow speeds up. Let's think about this. Blood pressure gradient goes up, blood flow speed increases. Yes, I would agree with that. That just means that, again, as your blood pressure gets higher and higher and higher, your blood's going to flow faster. Then we have blood flow is inversely proportional to peripheral resistance. So if peripheral resistance increases, blood flow is going to decrease. Again, I would agree with that, right? So as the blood becomes stickier, it's going to be more difficult for the blood to flow. Therefore, blood flow will decrease. What we end up with is this equation of blood flow is equal to the blood pressure gradient over resistance. So peripheral resistance is more important in influencing local blood flow, and this is just because of the fact that it's easily changed by altering blood vessel diameter. All right, then we have systemic blood pressure. Pumping action of heart generates blood flow. That makes sense, right? The heart pumps and blood flows. And pressure is going to result when flow is opposed by resistance. And then systemic pressure is highest in the aorta and declines throughout the pathway. Again, that also makes sense because, again, the left ventricle is that thicker ventricle is going to be pumping. And as it pumps, and it's the first place the blood's going to go after it leaves the ventricle is into the aorta. And then from there, it's going to go into smaller and smaller vessels. And like we've talked about in the previous talk, part 1, and as it goes down, the actual pressure is going to drop. And what happens is, and we're going to talk about this, is it gets lost as heat, really. And steepest drop occurs in arterioles. So, trying to get a cursor, here we go. All right, we have our aorta here, pretty steady pressure, still relatively steady in the arteries, and then we have a big drop off in the arterioles. And then even more so in the capillaries, venules, veins. But the biggest drop, again, is in the arterioles. And then arterial blood pressure is determined by 2 factors: the elasticity of the arteries close to the heart and the volume of blood forced into them at any time. And blood pressure near the heart is pulsatile, which means it rises and falls with each heartbeat. And then we have the terms for blood pressure, and this is systolic and diastolic. So systolic pressure is the pressure exerted in the aorta during ventricular contraction. Left ventricle pumps into the aorta, imparting kinetic energy that's going to stretch the aorta, and it's going to average about 120 mmHg in a normal adult. Now, if the person has high blood pressure or low blood pressure, that's going to alter that number a bit. Diastolic pressure is the lowest level of aortic pressure when the heart is at rest. And then we have pulse pressure, which is going to be the difference between the two. So it's just systolic pressure minus diastolic pressure. And then pulse is the throbbing of arteries due to the difference in pulse pressures, and this can be felt under the skin. Excuse me. And then we introduce the concept of mean arterial pressure. And this is the pressure that's going to propel the blood to the tissues. Now, as you get toward the end or near the end of the arterial tree, the pulse pressure is going to phase out and flow will become non-pulsatile with a steady MAP, which is mean arterial pressure. And then we get into this next sentence here, which is actually starting to get into how to calculate out mean arterial pressure. And the heart's going to spend more time in diastole, so it's not simply just an average of diastole and systole. It is actually, again, I'm not going to ask you to calculate this stuff out, guys, but you do need to know the concept. So mean arterial pressure is calculated by adding diastolic pressure to 1/3 pulse pressure. So as an example, let's say the person's blood pressure is 120/80, which means their systolic is 120, their diastolic is 80. What you're going to do is you're going to subtract the two to get pulse pressure. So 120 minus 80 is going to give you 40. So to calculate out mean arterial pressure, what you're going to do is you're going to add the diastolic pressure, which is 80, plus 1/3 of pulse pressure, which is about 13. So this is going to give you 93 mmHg. Pulse pressure and mean arterial pressure are both going to decline as you get further away from the heart. Vital signs are going to include pulse, blood pressure, along with things that we don't talk about in this chapter, which would be respiratory rate and body temperature. You can take a person's pulse. The most routinely used place is the wrist, and that's going to be a radial pulse. But there are also other clinically important pulse points. There are also pressure points, and these are areas where arteries are close to the body surface, and they can be compressed to stop blood flow in the event of hemorrhaging. And these are just places that the pulse is most easily palpated. And then measuring blood pressure is done indirectly with auscultatory methods using a sphygmomanometer. And auscultatory methods means listening. So what the person's going to do is they're going to use a stethoscope and they're going to listen for sounds. So a cuff will be wrapped around the arm superior to the elbow. The practitioner will increase the pressure in the cuff until it exceeds systolic pressure in the brachial artery. Now, sometimes those people will pump it up to like 180, which I think is just extreme, but they will. And then the pressure is released slowly, and the practitioner is listening for sounds of carot cough with the stethoscope. Now, what they're listening for is whenever they get to the systolic pressure, excuse me, which is normally less than 120 millimeters of mercury or mmHg, you're going to hear a sound as the blood starts to spurt through the artery, and that's the carot cough sounds. And then you continue to release the pressure, and eventually the sound disappears because the artery is no longer constricted, the blood's flowing freely, and that's going to be diastolic pressure, usually less than 80. Then we have capillary blood pressure. These are going to range between 35 and 17 mmHg at the end of the bed. And then low capillary pressure is good because, one, high blood pressure would actually rupture the thin-walled capillaries, and most capillaries are pretty permeable. So low blood pressure actually, or low pressure, forces the filtrate into the interstitial spaces. And then we finally get to venous blood pressure. And this changes little during the cardiac cycle. There's a small pressure gradient, only about 15 mmHg. Now, if you cut a vein, because it's a low pressure, the blood will flow out smoothly. But if you cut an artery, blood will actually spurt out because the pressure is much higher. The low pressure is due to the cumulative effects of peripheral resistance. So this is what I was kind of referring to earlier. I was saying that it's lost its heat, right? So as the blood flows through the blood vessels, there's friction. It's encountering friction, and as it encounters friction, energy is lost as heat, and so that's going to blood pressure goes down. Low blood pressure or low pressure of the venous sides requires adaptations, to help with venous return. And so there are three factors that we are going to talk about here. And one is the muscular pump. So skeletal muscles contract and just kind of milk blood back to the heart. And then we also have those valves and veins, which will help to prevent backflow. Then there's the respiratory pump. So pressure changes during breathing help move blood toward the heart by squeezing abdominal veins as thoracic veins expand. And then finally, we have sympathetic venoconstriction. And so under sympathetic control, the smooth muscles constrict, pushing blood back toward the heart. And this would be the example of the muscular pump. So muscles contract and it just pushes blood back towards the heart. And here's your question. This is all I have for you.